we are going to look at the development and congenital malformations of the face. Now, this is the third lecture series we are having on the embryology of the head and neck region. In the first part, we laid down some foundation regarding what we call pharyngeal apparatus. And in the second part, we looked at development of the endocrine glands of the head and neck region. So we focused on pituitary, thyroid, and parathyroid. So in this third lecture on development of head and neck, where we are focusing the face, we will talk about the face as a whole, but we'll also talk about some important facial structures, the tongue and the palate. So we'll discuss the tongue, the palate, and the face as a whole. If you remember, that is the outline that I was telling you about regarding the lecture series of head and neck development. So the lecture on pharyngeal apparatus and the derivatives has already been addressed. The lecture on development of endocrine glands of head and neck has also been addressed. So we're doing this third part. There's another part that will come later again, where we're going to look at development of the eye and the ear. So let's start with development of the tongue. As we agreed in our previous sessions, when you asked development of a structure, it is important that you first tell us about the embryonic origin of that structure. So as with regard to embryonic origin of the tongue, the site of origin is usually the floor of the primitive pharynx, or you can say the dorsum of the tongue. As long as you know that the tongue there, as long as you know that what you're talking about has not yet been formed. So basically it begins at the floor of the primitive pharynx. The embryonic pharynx is very primitive at this point, but we'll still have a roof, we'll still have a lateral walls and the floor. The tongue has two gross anatomical parts largely. We have the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. From your gross anatomy, you understand that. And the two are usually separated by what we call the sulcus limitans. Now, the two parts of the tongue have different embryonic origin. The anterior 2/3 and the posterior 1/3 develop from different structures, but those structures are just swellings at the floor of the tongue, and those swellings are called lingual swellings. So we have lingual swellings responsible for formation of the anterior 2/3, and we have lingual swellings responsible for the formation of the posterior 1/3 of the tongue. The image here shows you image of the floor of the primitive pharynx. And we are seeing here multiple swellings related to the pharyngeal arches. So this is the one related to the first pharyngeal arc, second arc, third arc, fourth arc as labeled there. On those arches, we see some swellings like the one labeled 1, another one labeled 2. And as time goes by, the one labeled 1 becomes that one, and the one labeled 2 is this. There's another one that appears somewhere here, which we can now see in this particular image, labeled 4 there. So these are the swellings that contribute to the formation of the tongue. I want to give them names. The first one here, which is labeled there, is called the tuberculum impar. These ones are called lateral lingual swellings. And the one labeled 4 is called the copula. But let's mention them with some great understanding in the next slide. Let's start with the anterior 2/3 of the tongue. So the anterior 2/3 of the tongue is derived from the tissues of the first pharyngeal arc, largely the tissues of the first pharyngeal arc. So in this image, you can see the region corresponding with the first pharyngeal arc. It forms initially using some swellings, as I told you earlier. The swellings that contribute to formation of the tongue are two types of swelling that are responsible for the formation of the anterior tooth of the tongue. They are paired lateral swellings. We call them the lateral lingual swelling. So we have that one and that one. These are the lateral lingual swellings. And you have one which is in the middle. We call the median lingual swelling. You can call them bud or swelling. So lingual bud or tongue swelling. The median lingual swelling is what is otherwise known as the tuberculum impar, the one that was labeled 1 in the previous slide. The lateral lingual swellings are the ones labeled 2 in the previous slide. So these lateral lingual swellings and the median lingual swelling are the ones that contribute to formation of the anterior 2/3 of the tongue. However, as time goes by, the lateral lingual swellings outgrow the median swelling. So that is to mean that the lateral lingual swellings grow faster. And because they grow faster, they outgrow the median lingual swelling. What is the end result of that faster growth? The end result of that faster growth is that now the right and left lateral swellings will merge in the middle and somewhat sandwich the median lingual swelling. This images capture that. So if this is the lateral lingual swelling, that's the other one, and that's tuberculum impar, which is the median lingual swelling. The lateral lingual swellings grow faster, and so they merge, as we can see in this particular image. You can see the way they have outgrown the median lingual swelling, which is at that point. So that is how the anterior 2/3 of the tongue will develop. How about the posterior 1/3 of the tongue? The posterior 1/3 of the tongue is derived from the tissues of the second to the fourth pharyngeal arches. The ones of the second is very minimal, really, and it even migrates anteriorly. And so we largely remain with the third and the fourth ones contributing predominantly. So in this image, we can see the level of the second arc there in yellow, the level of the third arc in yellow, the level of the fourth arc in yellow. That structure that formed there, that swelling that formed, that lead to formation of the posterior 1/3 of the tongue is known as the copula or the hypobranchial eminence. So the hypobranchial eminence is derived from the tissues of the second, third, and fourth. But remember what I mentioned, predominantly the third one, and to some extent the fourth one. The second one contributes very little to the hypobranchial eminence. And that is why we can say with a lot of confidence then that the posterior 1/3 of the tongue is predominantly derived from the tissues of the third pharyngeal arc. Now that we've mentioned that the anterior 2/3 have different swellings from the posterior 1/3, what happens? There's a separation between the two. The separation between the two is a groove, which we call the sulcus terminalis. So the sulcus terminalis separate the anterior 2/3 of the tongue from the posterior 1/3 of the tongue. And so this image again that I showed you, I'll show it to you again here. Look at the blue region representing the tissues of the second arc. As time goes by, it doesn't really contribute much. Look at the tissues that represent the third arc. As time goes by, we see that that's the one that contributes predominantly. The tissues of the fourth arc are here. As time goes by, we note that that one is largely just around the region of the epiglottis. So much of the posterior 1/3 of the tongue is largely from the tissues of the third pharyngeal arc. Now, the derivatives that form the third, that form the posterior 1/3, and the derivatives that form the tissue that form the anterior 2/3 eventually merge. In simple terms, I'm saying that the anterior 2/3 of the tongue merge with the posterior 1/3 of the tongue. The line of union of the two is that V-shaped groove, which we call the terminal sulcus or sulcus terminalis. At the center of the sulcus terminalis is a small depression, which we call the foramen cecum. Why do we have a foramen cecum? We have a foramen cecum because this is where the thyroid gland began to form as it descended downwards as the thyroglossal duct. You remember from the second lecture that there's a thyroid gland developing from the tongue. So it's a downgrowth from the floor of the tongue or the floor of the primitive pharynx. So it goes down. As it goes down, there'll be a thyroglossal duct that usually involute, but the cranial part of the thyroglossal duct does not involute. This cranial part of the thyroglossal duct that does not involute is the one that gives you that depression, which we call the foramen cecum. Great. So this image shows you earlier development of the anterior 2/3 tongue and later development. It also shows you the position of the origin of the thyroid gland and how with the time it becomes tiny. It shows you how the tissues of the lateral lingual swelling are the one that eventually contribute a big part of the anterior 2/3 of the tongue. But yes, tuberculum impar still contribute a little at the center there. It also shows you how the tissues of the third arc are the ones that predominantly make up the posterior 1/3 of the tongue. That image that we saw there, we can also replicate it on this particular one, but the same storyline is passed. So take note that anterior 2/3 is from the lateral lingual swelling predominantly, followed by tuberculum impar. The posterior 1/3 of the tongue is predominantly from the copula, which is largely from the third pharyngeal arc, but the fourth arc tissues contribute around the epiglottis. And so that means that the epiglottis itself will come from the fourth arc, fourth pharyngeal arc. The tissues of the second arc largely disappear, but the nerve of the second arc will eventually be innervating the taste buds within the anterior 2/3 because of migration. What happens is that the tissues of the second arc migrate, but then involute, but the nerve that was supplying them merge into the anterior 2/3. That's why the facial nerve supplies the anterior 2/3 of the tongue for taste sensation via the nerve called chorda tympani. But the trigeminal nerve supplies the anterior 2/3 of the tongue for general sensations. Remember, trigeminal nerve is a nerve of the first pharyngeal arc, or let's say the mandibular nerve is a nerve of the first pharyngeal arc. So mandibular nerve will supply the anterior 2/3 of the tongue for general sensations. The nerve of the second pharyngeal arc, which is facial nerve, via its branch chorda tympani, is the one that will supply the taste buds in the anterior 2/3 of the tongue. Then the posterior 1/3 of the tongue, because it's predominantly from the third arc, the nerve of the third arc is the one responsible for supplying that, both for general sensations as well as for taste buds, which is spatial sensation. And that nerve is a glossopharyngeal nerve. So glossopharyngeal nerve supplies the posterior 1/3 of the tongue. The tissues around the epiglottis and the rest of the pharynx would be supplied by vagus nerve. And that is why the taste buds around the epiglottis are supplied by vagus nerve. Remember that the nerve, the fourth arc. Now we've accounted for the mucosa of the tongue, on the surface of the tongue. How about the muscles of the tongue? Where are the muscles of the tongue coming from? The muscles of the tongue have a different embryonic origin. While the mucosa of the tongue came from those swellings that you talked about, the musculature of the tongue is predominantly derived from myotomes in the occipital region. Now, perhaps you need to be reminded what a myotome is. Remember, we had what we call intraembryonic mesoderm. Then intraembryonic mesoderm divides into three: paraxial, intermediate, and lateral plate mesoderm. The paraxial mesoderm then divides into three again: dermatome, myotome, and sclerotome. Myotome is the one that gives you skeletal musculature. Now we are saying the myotome in the occipital region, so we call them occipital myotomes. Occipital myotomes give rise to the tongue musculature. You can see that they are far away from where we expect the tongue to be. So what happens is that these myotomes migrate from the dorsal aspect, they migrate ventrally and invade the tongue. As they do so, they move with their nerve supply. So the nerves that were supplying them here is the 12th cranial nerve, the hypoglossal nerve. Those myotomes migrate together with the hypoglossal nerve to invade the tongue. And that is why tongue musculature are supplied by the hypoglossal nerve. The only exception to that rule is the palatoglossus muscle. The palatoglossus muscle does not come from the occipital myotomes. Palatoglossus muscle come from the tissues of the fourth pharyngeal arc. And because of that reason, palatoglossus is supplied with the nerve of the fourth pharyngeal arc, which we can say is vagus nerve, or if you understood from the previous lecture, you can still say it's the cranial accessory nerve, except that from outside, what we see is vagus nerve, not cranial accessory nerve. To be safe, you can just say the pharyngeal plexus. So that is the account of the muscles of the tongue. Now we can look at some congenital malformations that affect the tongue. There are a number of congenital malformations that can affect the tongue, but I can highlight on a few common ones. One is what we call ankyloglossia. Ankyloglossia refers to tongue tie. So you can call it tongue tie or ankyloglossia. It is when the tongue is anchored down to the floor of the mouth by this tissue here, the frenulum of the tongue. So the reason is that perhaps this frenulum, the tissues of the frenulum of the tongue fail to degenerate, and so the tongue is anchored down. Remember, we agreed that the tongue is originally arising from the floor of the primitive pharynx. So if the attachment on the floor of the primitive pharynx does not free at this anterior level, then you're going to have tongue tie. That's what we call ankyloglossia. Second anomaly of the tongue is what we call macroglossia. It simply means a very large tongue. So this is a tongue that fills the whole mouth, and the baby might even be struggling to breathe because the tongue has filled the whole mouth. It is due to overproliferation of the lingual swellings. So if the lingual swellings overproliferate, you have overproliferation of the tissue of the tongue, you're going to get macroglossia. The opposite is true. We may also have what we call microglossia, which means small tongue. So this is due to underproliferation of the tissues of the tongue. We give you a very tiny tongue. You'll even be looking into the mouth of the baby and wondering, where is it? That's a microglossia. You can also have what you call furrowed tongue. So furrowed tongue is what you see here. This is a tongue with cleft. This one will be more of acquired though, but rarely congenital, but can also happen congenitally. Now, think about if the right and the left lingual swellings the right and left lateral lingual swellings responsible for formation of the anterior tongue fail to merge, what would happen? You'll have a tongue that looks like that of snakes, a tongue that is split into two. We call that bifid tongue. Again, it has been reported that some babies may be born with a bifid tongue. So just have in mind that some people may have a split tongue. That's what we call bifid tongue. Failure of fusion of the right and left lateral lingual swelling. That is about the tongue. Now we can talk about the face. Now, regarding face development, the face develops from three important swellings. We call them facial swellings or facial prominences. These three facial prominences form around the stomodium. The stomodium is the primitive mouth. Now, when you look at this ugly thing, we can see that that's the primitive mouth, what we call the stomodium, or that one. The swellings we're talking about form around the stomodium, which means they form around the primitive mouth. What are the names of the swellings? We have what we call the frontonasal prominence. This massive thing here is the frontonasal prominence. Now we call it frontonasal prominence because there are two prominences within it. The frontal prominence and the nasal prominence. So we call it frontonasal prominence. The second prominence is called the maxillary prominence. The maxillary prominence, this one here. Usually the maxillary prominences will not merge in the midline. So they're on either side of the stomodium, as we can see there. But in this image, that is the maxillary prominence. You can also call it maxillary process. Take note that the maxillary process or prominence are initially not merged. So they're on either side of the stomodium. The third prominence is what we call the mandibular prominence. This is the mandibular prominence, or that one. So that one also merges in the lower part of the stomodium. So your face and my face were originally looking like that one, whether you like it or not. It was originally looking like that at some point in development with those three major prominences. I want us to account for each of the prominences and state how they develop so that eventually you have the final face. We'll start with the frontonasal prominence. So this frontonasal prominence develop a thickening at the inferolateral aspects of the swelling. That thickening is a thickening of the ectoderm. The ectoderm on this surface thickens. That thickening is known as the nasal placode. The nasal placode represents the site of the future nostril. That hole that leads to the nasal cavity is the nostril. So this is the nasal placode, the left one, and that's the right nasal placode. So that thickening appears first, formation of the nasal placode. In this image, you can see the nasal placode there. There are thickenings on the frontonasal swelling. As time goes by, the nasal placode invaginates, which means that it forms a groove inside, like a pit, a depression going in. That is the nasal placode. It forms a pit going in. The pit going in is called the nasal pit. So while this is the nasal placode, there's a nasal pit, a depression at the center of the placode, representing the position of the future nasal cavity really. And so this image shows you the pit there. That one does a pit. Because of the presence of the nasal pit, we can say this now, that the nasal pit separates the nasal prominence. I told you that we call it frontal nasal because there are two prominences, the frontal and the nasal prominence. So the nasal pit separates the nasal prominence into two. We'll have a lateral nasal prominence and a medial nasal prominence. Or in this image, we'll have a lateral nasal prominence and a medial nasal prominence. And I want you to see where the medial is and where the lateral is in relation to the maxillary prominence as well. In this particular diagram in the middle there, there's a lateral nasal prominence and there's a medial nasal prominence. That's the nasal pit. Maybe that one is much better, lateral and medial. So the whole of this is the nasal prominence and this is the frontal prominence. The whole thing is frontal nasal prominence. Right, so that's the account of the frontal nasal prominence. I'll be telling you the derivatives of each of the prominences in another slide. Now let's give an account of the maxillary prominence. This is the maxillary prominence on either side of the stomodium. The maxillary prominences are originally not joined together. So what happened to them? They usually grow anteromedially. And because they're growing anteromedially, so that means they're growing eventually towards the midline. As they grow towards the midline, they push the medial nasal prominence. It is tempting for you to think that the lateral nasal prominence is the one that is likely to be pushed, but no, based on that anatomy. Look at that. If this is a lateral nasal prominence and this is a medial nasal prominence, this is the maxillary prominence. If this one grows that way, it will be pushing the medial nasal prominence. It doesn't push the lateral, it pushes the medial. It pushes the medial nasal prominence towards the midline. What will the maxillary prominence become? From this image, we can see what the maxillary prominence will eventually become if we follow through in this particular column. That's the maxillary prominence, and we sit there as well, and then we sit there as well. So we can conclude by saying that the maxillary prominence contributes to formation of the upper lip. It also contributes to the formation of the bone inside there, which will be the maxilla basically, so the upper jaw. And it will also contribute to formation of the palate. We are going to see how it contributes to the formation of the palate shortly. So those are the contributions of the maxillary prominence: the upper lip, the upper jaw, and the palate. We'll see which part of the palate is formed by this one. Now, let's try the medial nasal prominence. We mentioned that the frontal nasal prominence has two parts, the frontal and the nasal prominence. And that the nasal prominence, which is this one, is divided into two by the nasal pit. The lateral nasal prominence and the medial nasal prominence. So I want us to give account of the medial nasal prominence, this one here. The medial nasal prominences are displaced medially by the maxillary prominences, as we've said. So this and that are pushed medially by the maxillary prominences, as I mentioned in the previous slide. Now, because of that, what happens? The right and the left medial nasal prominences fuse in the middle. The fused medial nasal prominences constitute what we call the intermaxillary segment. And why that name? Because they're between the maxillary prominences. So we call them the intermaxillary segment. The intermaxillary segment, which is this part or that part, in this particular image, this is the intermaxillary segment. The intermaxillary segment contributes to formation of the following. One, the philtrum of the upper lip. Now the philtrum is that groove in the upper lip. We call the philtrum. That groove that is on your upper lip is what we call the philtrum. It forms that one. It also contributes to formation of what you call the primary palate. We are going to talk about that shortly. And it contributes to the formation of the incisor region of the upper jaw. You see, the maxillary bone has a very wide region that will be occupying the teeth. So the region of the maxillary bone that hold the incisor teeth, that region comes from the intermaxillary segment. It comes from the fused medial nasal prominences. So these are the derivatives of the medial nasal prominences that eventually fuse. So they form the structures in the middle of the upper part. So you can think through that, just things in the middle here, the philtrum, also the primary palate, also the region of the upper jaw contributes to that. And you can still add even the nose, you know, that region between the right and the left nostril, that column there is also coming from this particular segment. So this image perhaps will help you to understand that very well. Start from the left side. So we have the frontal nasal prominence, which has the frontal and the nasal prominences. Because of the formation of the nasoplacode and then the nasal pit, the nasal prominence is divided into two. The medial nasal prominence in yellow and the lateral nasal prominence in blue. So this becomes the frontal prominence, which is that one or that one or that one. This blue and yellow are the nasal prominences, medial and lateral. The other color there is a maxillary prominence. Originally, as we can see, the maxillary prominences are not originally fused. And so the gap between them is the stomodium, the future mouth. These maxillary prominences grow medially. The medial growth of the maxillary prominences push the medial nasal prominences towards each other. And so in the third image, you see the medial nasal prominences have fused. This fused medial nasal prominence is what we call the intermaxillary segment, because it's between the right and left maxillary prominences. What will it become? In the last image, we can see what it becomes. So it will form some part of the palate, which we call the primary palate. I will talk about that shortly. It also forms part of the maxillary bone, but which part of the maxillary bone? The part responsible for holding the incisors. Then it forms the philtrum, that groove on the upper lip, and then it forms that ridge between the right and the left nostril. So those are the derivatives of the intermaxillary segment. We can also conclude on the derivatives of the lateral nasal prominence from this image. The lateral nasal prominence will form the ala of the nose and the lateral margin of the nose as well, as we can see in that particular image. How about the maxillary prominence? We can see it contributes to formation of the upper lip, but the lateral aspects of the upper lip generally, as well as the lateral aspects of the upper jaw, which means the maxilla. And we are going to see in the next slide, on the coming slides, that maxilla also contribute to formation of the palate, something called now the secondary palate as opposed to primary palate. Let's give an account of the mandibular prominence. This is the mandibular prominence. It's on the lower part of the stomodium. Usually, the right and the left mandibular prominences usually grow and merge in the middle. And so we already have the mandibular prominence here merged. Before, in this one, they're not yet merged, but now there we can see the merger, and here they're already merged. Because of that, the mandibular prominence will contribute to formation of a number of things again. Now, think about the region at the lower part of your mouth. So that is the mandibular prominence, or that one. It will contribute to formation of the lower lip. It will also contribute to formation of the lower jaw, which is the mandible. So that's the account of the mandibular prominence. In this particular image, we can see the mandibular prominence there. And so it makes sense that it accounts for formation of the lower lip and the lower jaw. Now, let's talk about something called the nasolacrimal groove. The nasolacrimal groove is a furrow that is present between the lateral nasal prominence and the maxillary prominence. Let's trace it here. So this furrow here is what we're calling the nasolacrimal groove. It's a furrow between the lateral nasal prominence and the maxillary prominence. As you can see, that furrow is extending from the position of the eyes to the position of the nose. We call it the nasolacrimal groove. Usually, it's originally a groove like that, but as time goes by, the groove become incorporated. What do I mean by that? The groove invaginates, but the tissues here cover it. Even though the groove invaginates, it retains its lumen inside. And so that luminal, incorporated lumen inside is what will become what we call the nasolacrimal duct. The nasolacrimal duct is a channel connecting the orbital cavity and the nasal cavity. So the nasolacrimal duct will not be seen on the surface because the tissues of the lateral nasal prominence and that of the maxillary prominence have grown and merged on the surface. But deep inside, there's a ductal structure that will be carrying tears from the orbital cavity to the nasal cavity. So that is how we have the nasolacrimal groove. Great. Now, let me give you a summary of those facial prominences and what they give rise to. Let's start the frontal prominence. So the frontal prominence basically gives you the forehead region, but it also forms the nasal bridge, the bridge between the right and the left eye. That ridge between the right and left eye is what we call the nasal bridge. So those are the derivatives of the frontal prominence. How about the medial nasal prominence? The medial nasal prominence has given us the philtrum of the upper lip. It also gives us the nasal tip and crest, that structure in the middle there, between the right and the left nasal pit. Of course, from inside, these are the ones on the surface, but inside, remember I told you it also contributes to formation of the primary palate, as well as formation of the incisor region of the upper jaw. The lateral nasal prominence form the ala of the nose. So this lateral side of the nose comes from the lateral nasal prominence, Maxillary prominence form the cheeks that we now have at this point. You can see that region. It also give rise to the lateral parts of the upper lip. So the lateral part of the upper lip and the cheek come from the maxilla. That's on the surface, but remember on the inside, the mesenchyme of the maxillary prominence will still give us the maxillary bone, the upper. It will also give us the palate, secondary palate for that effect. Mandibular prominence, lastly, gives us the lower lip. Sorry, it gives us the lower lip, but from inside, remember, it will also give us the lower jaw. So that's the story about development of the face and the derivatives of the various facial prominences on the surface of the face. The story of development of the face only makes too much sense if we also talk about that of the palate. So let's talk about the palate. Now, the palate has two embryonic origins, or rather two embryonic segments. There's this yellowish part, and there's this other part. They have different embryonic origins. This yellowish part is what we call the primary palate. The primary palate is derived from the intermaxillary segment. The intermaxillary segment is the fused right and left nasal swelling, or fused right and left nasal prominence. So that is what will give us the primary palate. Remember, the intermaxillary segment also gives you the upper jaw corresponding to the incisors. It also gives you the upper lip in that region, the region of the philtrum, and it also gives you the nasal tip and crest. But here, we're talking about the primary palate. This other region is what we call the secondary palate. The secondary palate is formed by shelf-like outgrowth from the maxillary prominences. The maxillary prominences develop some outgrowth in form of shelves. Those shelves grow towards each other and fuse and form the secondary palate. So the tissues here are outgrowth from the maxillary prominence in form of shelves. Let's look at that. We look at how the palatal shells from the maxillary prominences develop. So if this is the maxillary prominence, that and that, these are corona section at the level of the developing or of the mouth and the nasal region. You can see even the nasal septum developing there at this point. Originally, those palatal shells are oriented obliquely downwards, as we can see. So they're somewhat directed towards the base of the tongue down there. However, as time goes by, this one changed from being oblique to being horizontal. So they take somewhat horizontal position. So this thing changed the orientation from being oblique to being horizontal. And so when they go horizontal, they'll go above the tongue. You can see in this image, they're initially below the tongue. But when they become horizontal, they'll go above the tongue. Once they've gone above the tongue, they fuse with one another. So the right and the left palatal shells from maxillary swellings fuse in the middle. And the fused right and left palatal shells is what will become the secondary palate. In this image, look at that. This is the palatal shell, now growing right and left and growing towards each other. There's still a cleft yet at this point. The yellow one is the primary palate from the intermaxillary segment. These are the things, the nasal septum, which you're seeing here. So this one and this one will come and fuse in the middle, and the nasal septum will also join them. And that's how we'll have the two nasal airways as well. Maybe this image is much better in capturing that. So let's start from the first image here. This is the developing tongue. Look at the palatal shelf, originally oriented obliquely downwards. But as time goes by, they change from oblique orientation to a more horizontal orientation. So this is it. Then at image C, we can see they're growing towards each other. And image D, we see that they've already fused. Now, once the secondary palate fuses, something important happens. Once the right and the left palatal shells fuse above the tongue to form the secondary palate, the anterior parts of the secondary palate undergo ossification, which means that bone formation occurs within the anterior parts of the secondary palate. And so that contributes to formation of the hard palate. The posterior parts of the secondary palate does not undergo ossification. And because of that, the posterior part of the hard palate lacks bone tissue. Therefore, we call it soft palate. So the soft palate does not have bone. The hard palate has bone. The muscles of the palate are largely on the side of the soft palate. They are derived from the mesenchyme of the fourth pharyngeal arc. And that is why, again, they'll be nervated by the cranial accessory nerve, although from outside we see that it's actually vagus, or you can just say pharyngeal plexus. So the images here show you how the different palates form: primary palate from intermaxillary segments, secondary palate from the shelves of the maxillary process. And here we see the two shelves coming together to fuse. And here we see that the two shells have fused. Now, the shells from that form the secondary palate, the shells from the maxillary prominence, fuse also with the primary palate. And we can see that one here. So there's also fusion between that of the secondary palate and that of the primary palate. Even though there's fusion, the fusion is not complete. And so there's usually a small hole that marks that separation. That small hole is called the incisive foramen. The incisive foramen marks the union between the primary palate anteriorly and the secondary palate posterolaterally. The nasoseptum grew from up, you remember, that's the nasoseptum, it grows from up, and usually it will eventually join the fused secondary palate. So that's why the nasoseptum splits the nasal airway into two. That captures that story of the nasoseptum having grown from up to fuse with the secondary palate that has grown. And this one captures the location of the primary palate and the location of the secondary palate. Remember, the posterior parts of the secondary palate do not undergo ossification, and so they remain a soft palate. Now we can finish with congenital malformations of the face and palate. We have a group of malformations that we call the facial cleft defects. They occur due to partial fusion or lack of fusion of the various prominences or the various structures that we mentioned today. So remember, it's either partial fusion or lack of fusion of the various structures. The one shown here, we can see a defect on the palate, also on the upper lip. So we call it cleft lip and palate, because a defect on the palate but also a defect on the upper lip. Now, this is unilateral, so you can call it unilateral cleft lip and palate. And the one to your right is bilateral. So this is bilateral cleft lip and palate. So how do we explain a cleft lip and palate? Here, we can say that the issue here on the first one, the palatal shelf that was forming the secondary palate did not fuse with another and also did not fuse with the intermaxillary segment. So failure of fusion of one palatal shelf with the other two structures, which means the corresponding palatal shelf and also the intermaxillary segment. So that this cleft here is a cleft of both the primary and the secondary palates. Here is bilateral, so the same concept except now right and left side. How about this one? Here we see a cleft involving just the palate. The lip is okay. So this is a cleft of the secondary palate. It's not the whole palate. So we call that one cleft palate, but to be more specific, you can call it cleft secondary palate. The issue here is that the right and the left palatal shelves of maxillary segments did not fuse. So you remain with that cleft there. Of course, surgery can be done, and that's what you see in the other image. How about this other one? So this other one is similar to what I showed you earlier, except that now the lip is not affected. So these are cleft primary and secondary palate without a cleft lip. So the lip side is okay, but here, you see this is the secondary palate, did not fuse the primary palate. So there's a cleft there, but there's also a cleft here. The right and the left secondary palate have not fused as well. So those are cleft palates. Lastly, we can have what you call the oblique facial cleft. This is the oblique facial cleft. It's when you have a groove extending from the eye towards the mouth there. That's an oblique facial cleft. It tells you that there was no good fusion between the maxillary prominence and the lateral nasal prominence. It can be as bad as what you see here, associated with a lot of malformations in the face affecting the eye because of there's no room for normal growth. Tissues are not growing normally. So this is bilateral oblique facial cleft. Remember, this is failure of fusion of the maxillary prominence with the lateral nasal prominence. Right, so that's what I had for you on that particular lecture on development and congenital malformations of the face. Thank you very much.